deep intramural myoma symptomatizing by any infertility problem or bleeding. Well, let's travel together through the cervical canal, going slowly. Give a chance for the fluid to open the way. As I always repeat, don't race with the water. Let the water go before you and then you follow. Now we are inside the uterine cavity. You can obviously see that there is a fundal cupping. This is septum looks like appearance is because of the bulge of the myoma. So the myoma is deep intramural. It's actually touching near serosa, near mucosa. So here is the plan. First, using the scissors to cut into the fundus, trying to reach and hit the myoma. Definitely have to be careful using the scissor, but I feel comfortable and not afraid of serious perforation because I know there is a tennis ball myoma above my head, above the fundus. So you keep cutting and try to reach the myoma capsule, which is distinguished very easily by the thin fibers, and you can see the myoma behind the transparent capsule. The plan was to open a window into the fundus. The location of the myoma is very awkward. It's not if it's anterior or posterior. You can open the window and then use the resectoscope directly. But here it is fundal location, deep intramyometrial, and I have to cut through the myometrial fibers trying to reach the myoma. So watch carefully, observe, and I'm coming back with very nice, lovely techniques. Yes, this is the capsule of the myoma. As I said, it's the thin layer, which is transparent like a transparent curtain. And you can see the body of the myoma behind this curtain. So open the blades, use one blade to dissect and to cut into the thin layer of the capsule. Yes, you can see the myoma body is behind the capsule. In fact, this was my not first try to do this technique. I did it before and failed. I tell you why I failed. Because I didn't open wide window enough to deliver the myoma. So here in this case, I learned the lesson and I extended the window from far one ostium till the other ostium. So you create a big space that I can deliver the myoma. Again, many colleagues might ask me what is the indication. The patient had failed IVF 4 times, and this was the only clue available. So the IVF people insisted to remove the myoma, and as I showed you, it failed to be removed laparoscopically because of extensive pelvic adhesion. Now, gently cut into this fine capsule, and you will see the myoma behind, and then we will proceed with an innovative idea. And now you go deeply, a little bit more deep in the space between the myoma and the myometrium, and use the scissor blades not only to cut, but to elevate, retract, push Scissors is not only a mechanical tool to cut. In hysteroscopy, you have only one instrument inside the uterus. So you have to make the best benefit out of it. Everybody is happy now seeing the myoma. Everybody feel sensation, desperate, frustrated. How can I pull it down? This is the myoma in front of me, but I am so frustrated, not able to bring it into the cavity, into my playground to dissect it, to resect it. So I go a little bit, but this is very dangerous. This is the capsule. So doing some hydrodissection by using a high jet of fluid. How to pull this myoma down? I need a screw, but there is no hysteroscopic myoma screw. Here is the trick. I inserted a 5mm laparoscopy screw side by side. Yes, again, it is side by side. The hysteroscope beside the laparoscopy screw. Yes, because the laparoscopy screw is 5mm. It cannot go through the channel of the office hysteroscopy. The office hysteroscopy takes 5 French, which is less than 2mm. So I had to dilate the cervix. Can you imagine the situation? Can you feel the terrible difficulty I was in? So here the distension is less because the cervix is dilated. And now I insert a laparoscopy myoma screw. It's large size. So handling the equipment, the right hand holding the laparoscopy screw, the 5mm, the left hand holding the office hysteroscope. You can see here the capsule of the myoma. It's dissected a little bit. Actually, the myoma is free all around, but still attached fundally to the rest of the fundal myometer. But there was some distance from the serosa. Otherwise, if I pull, I will bring the myoma, the serosa, and the bowels. It's a scary movie, okay? So, screw and pull down. Again, should I be afraid that the screw will perforate? Definitely no. Again, this is a tennis ball myoma, and the screw is only 5mm. The length of the screw is 5mm. So whatever the screw goes into the myoma volume mass, it will not transfix the myoma and reach the abdominal cavity. So when I pull, sometimes I feel that the screw will slip. So screw again to get a fixed attachment of the screw to the myoma, and keep screw and pull. Sometimes the pressure of the intracavitary is less because of the escape from the dilated cervix. The myoma is coming down. It's almost now at the internal os. So the whole body, or I can say the myoma now, is converted into type 1 myoma. Here I am at the level of the internal os, so I feel very comfortably. Screw more, and pull down. So the far up intramural myoma converted now to be submucous. I screw off the laparoscopic screw, go out, and then I started myoma resection. My dear friends, enjoy the beautiful end of the procedure. I didn't include it because it's a standard myoma resection, and this is the window in the fundus with the big cavity, which is the myoma bed. Nice, neat, and clean. And when you decrease the fluid pressure, the edges of this big defect coapted together, get close to each other, and actually this patient had a post-operative ultrasound 2 months later to show a very nicely healed fundus. Again, this is the edges of the window where the myoma is extracted. My dear friends, this technique I designed 9 years ago, and I'm very proud to see many colleagues are doing it much easier now because of the availability of myoma screw. So sharing this technique to share with you how perseverance, how passion can help you and push you to develop new and creative idea. This is the final view, and this patient had IVF later, and she had successful 2 twin girls after removal of this fibroid. This is Usama Shawki from Cairo, Egypt.